Hello, my name is Dr. Orin Zwick. I am an oculoplastic surgeon, and I'm going to have a brief discussion on eyelid lumps and bumps on behalf of optometric education consultants. I'd like to talk to you about the importance of really looking at the external structures of the eye, especially the eyelids, while doing a formal eye exam to be able to pick up things for patients that either they've presented for, or that you just happen to pick up on exam that might just save somebody's life. Eyelid lesions are typically broken up into three categories: inflammatory, benign, and malignant. Easy to break them up into those categories, important to differentiate one from the other in order to know the proper management and whether referral is indicated to your oculoplastic specialist. We see so many of these inflammatory lesions every day, and it's important to differentiate between styes and chalazions just to give the patient peace of mind as well as to know which treatment will work the best. Styes or hordeolum tend to be really on the external edge of the eyelid, usually from a blocked eyelash follicle. They're tender. Patients present, they wake up, they feel like when they're blinking, they feel something in their eye or it's just bothersome. They tend to be a tender red nodule, internal or external, and the treatment really is warm compresses to help the body absorb this inflammatory infectious lesion. Um, Typically, they're treated with an antibiotic and or steroid ointment or eye drop, in addition to sometimes requiring an antibiotic pill if it looks like a preseptal cellulitis is developing, which is more of a really swollen, full, tender, inflamed eyelid. Chalazions, again, very, very common. We see them all the time in the office. These are the body's reaction to meibomian glands getting blocked and the oil leaking out, causing a foreign body or granulomatous inflammatory reaction. They are, they tend to be firm, nodular, sometimes well circumscribed, internal or external. And the treatment for chalazions, again, 50% can resolve on their own with time, again, with warm compresses, depending on when you're catching it. Topical antibiotic steroid combination ointments tend to be great to help these. Again, if there is an inflammatory infectious component, you can treat with an oral antibiotic to see if it resolves. And if not, which again is about 50% of the time, you give it about a month. And if they're not better, they required either an injection with a steroid, which can help decrease that inflammatory process, or an excision of the chalazion. Moving on, benign eyelid lesions. Again, these are things that you're going to see in the office all the time, and the important thing is to be able to differentiate between benign versus malignant to know when, the radar needs to go up to send these out for further screening. Cysts, moles, papillomas, keratoses, xanthalasma are all benign lesions, and they present in different ways. This lesion here looks like a raised, stuck-on keratotic lesion, pigmented. Eyelid cysts we see all the time. They tend to occur, interestingly, um, along the lateral canthal or medial canthal area, and the differentiation between these are either an eccrine hydrocystoma, which is a fluid-filled cyst, or an inclusion cyst, which tends to be more sebaceous material from a plugged pore. Both occur equally around the eyelids. The management of an eccrine hydrocystoma is really oftentimes either leave it alone if it's not bothering the patient, or incision and drainage, and lastly, if they get real big, excision is required. Inclusion cysts, again, can be incised and drained, or excision can be performed. Got to be careful, obviously, near the lacrimal area to not damage the nasolacrimal duct when removing these things. And, sometimes there's a concern that this might be a basal cell, and if a biopsy is indicated, that's fine. You'll know right away when getting in here whether there's fluid-filled sac, which really is consistent. But sometimes these will surprise you. So moles. Moles can occur anywhere on the body, otherwise known as nevi or nevus. These are benign. What really differentiates these is that they tend to be very smooth, dome-shaped lesions along the lid margin if they are. They can occur anywhere on the eyelids, but when they're on the lid margin, you can see in this upper left picture, a nice smooth dome-shaped growth. Now, a big thing to differentiate this from a basal cell or a skin cancer is eyelash loss. And these tend to not disturb or degrade the surrounding architecture of the eyelid. They tend to be very smooth and well defined. It can be pigmented or non-pigmented. These can be excised if they start to impair or impede on the visual axis of a patient, or obviously if there's a suspicion of something progressing. Keratotic lesions, smooth, waxy, stuck-on appearance. Um, these sometimes can be called, some people call these skin tags. They can present more pedunculated where they start to grow out a bit more and hang. These, again, benign. Observation is typically indicated, but if they bother a patient, they can certainly be excised depending on the size of the lesion. Now let's move on. These are the ones that you don't want to miss. Malignant lesions. Skin cancers occur anywhere on the body, but can certainly present on the eyelid. And these oftentimes they're non-painful. So it's up to you to figure out, is this something that needs to be dealt with? Because you could save a patient's life if you manage and treat this properly. This one on the picture is a large, obvious malignant lesion. It is what's called a keratoacanthoma, which is a subtype of a squamous cell carcinoma. Signs of growth, eyelash loss is a huge one. Ulceration, bleeding, or just lesions that don't go away should raise a red flag and have these evaluated further. The four main types of eyelid cancers are basal cell, squamous cell, sebaceous cell, and melanoma. Basal cells by far are the most common. These tend to all require a biopsy followed by further excision and repair of the eyelid. And excision can be performed either by an oculoplastic surgeon or a Mohs surgeon who specializes in an aspect of dermatology where they excise and remove skin cancers. So basal cells, let's move on. These, if you're going to guess and you're worried about a skin cancer, basal cell is your guess. 90% of all skin cancers on the eyelids are basal cells. They have a very characteristic presentation, but again, some can be misleading. They have especially in this picture on the upper left, a raised, heaped up lesion with heaped up edges, pearly in color, with a central ulcerated core. Eyelash loss and distortion of the architecture of the eyelid all go along with what a basal cell can do. They can be crusty and inflamed and scaly, as in the right top picture. On the lower left picture, you can see that just distortion of the eyelid margin. And again, these things can go for a while without being detected. So really important to try to pick up something that seems like there's a distortion of the normal eyelid architecture and lash loss, which again raises a red flag. Bottom right, again, ulceration, distortion of the lid margin, basal cell. The bigger they get, the larger the defect's going to be and the bigger the repair. So the sooner you can catch them and send them, the better for the patient. Lastly, we're going to go on to squamous cell, which is the second most common eyelid skin cancer, but again, a much smaller percentage than basal cells. These can start as what's called an actinic keratosis, which is more of just a scaly, rough appearance of the lesion. Now, they are more aggressive, they're red, scaly, they grow quicker, and they can actually invade the orbit. So these you want to be able to catch quicker before they cause serious damage. Now, the picture on the top shows this small area on the lateral aspect of the upper eyelid that's just, again, a scaly, inflamed lesion, which ended up being a squamous cell carcinoma. This one on the bottom right, you may think, oh, obviously there's something wrong there, but this patient thought for months, maybe even years, that it was her glasses that was irritating the corner of her eyelid. So she let it go and it became a real big deal when it had to be removed. I'd like to thank you and Optometric Education Consultants for allowing me to do this talk. This is just a brief introduction of eyelids lesions. I've got plenty more to talk about. I'd like to do a further interactive, longer discussion down the road because I think it's really key to be able to pick these things out, and it's fun sharing this knowledge. So, thank you.